Hello, everyone. I'd like to welcome you to today's activity entitled New Perspectives on the Management of Generalized Pustular Psoriasis. My name is Leanne Punch, and I am a dermatology nurse practitioner practicing for Doc's Dermatology in Cincinnati, Ohio. I will be joined later in this activity by my incredible colleague, Stephanie Zimmerman. Stephanie is a dermatology nurse practitioner at River Chase Dermatology and Cosmetic Surgery in Naples, Florida. I'd like to thank Behringer Ingelheim for providing an unrestricted educational grant to help support this education. And now let's get started. So when we talk about generalized pustular psoriasis, I think it's important to sort of understand, well, what are our goals and how do we measure success? And, I think primarily we are looking at those systemic manifestations and how can we best control them. So if they're febrile, if they are having systemic inflammation to the degree that it's causing fever, basically it's controlling that fever. It might be prevention of some long-term side effects of uncontrolled inflammation, like cardiometabolic failure, or control of some comorbidities like cholangitis, control of that systemic full body inflammation that is so common in all forms of psoriasis, even though this is its own entity. I think rapid control of these pustules and prevention of new areas of flaring is huge. And the reason there is because we recognize that these newer areas are sort of involved in this crazy cycle and poor quality of life, and really removing a patient's ability to feel like they're controlled in their life. When they're in these crazy cycles of flare and spread, they feel like the disease itself is controlling them. We want to prevent acute respiratory distress syndrome. We want to manage any comorbidities or concern for psoriatic arthritis. We certainly want to control their pain, any itching, any erythema, any swelling in their skin. We want to prevent renal failure. And we really, at the end of the day, want to prevent future flares from occurring. And so, how do we measure quality of life? Well, in the dermatology setting, we have this thing called DLQI, or Dermatology Life Quality Index. This is, in fact, a patient questionnaire. Easily in your clinic, you can print out a copy of this and laminate it and give a patient a dry erase marker for them to easily answer these questions. Or if you have access to an iPad or a computer device, a tablet, they can actually go and answer the questions themselves. And what this does is it gives us a really good understanding about how is this patient handling this dermatologic manifestation. And you can use this for any dermatologic situation or condition. And I think with generalized pustular psoriasis, it certainly is a type of inflammatory skin disease that tends to affect a patient's quality of life negatively. And so it would be very appropriate to give them one of these inventories. If they get a low score of 0 to 1, you can rest assured that there's really no effect on their quality of life. That never happens in my clinic, at least. A small effect is a 2 to 5. This is typically a patient that is very well controlled, often on some form of a systemic therapy. A moderate effect, somebody 6 to 10, is somebody who really is just not that bothered by their disease. In a severe way, at least, but it's there, at least in its underpinnings, but they may not feel that it's completely controlling them. 11 to 20, very large effect. This is somebody who, we are just shy of that 911 emergency here. This patient is by by these numbers reflecting that this disease is absolutely controlling them, and that there are some things in their life that they aren't doing, or some things in their life that they're doing differently because of this disease. And then an extremely large quality of life effect is that 21 to 30 score. I will tell you, we see these in my practice. And when you see 21 or higher, this is really, really an absolute 911 emergency. I've got to respond. I've got to get this better. So, in terms of treatment options, I think topical therapies are definitely part of our consideration. I think, regardless of what I do in addition, I'm probably going to throw on a topical therapy. But keep in mind, we have something that is by default generalized, meaning we're affecting a large part of their body. And I think because of that, I'm really going to lean very heavily on systemic therapy, and I'm going to lean less on topical therapies. And topical therapies, I might just be using for like fingertips to try to drive away some of the localized inflammation there, to try to give my patient some pain relief. Then we have corticosteroids. And I think corticosteroids, generally speaking, are very inexpensive. They're definitely not something I would lean on for the long term, but specifically initially, while I may be waiting for a histopathology result to occur, to return, or some other form of testing, I'm probably going to use some corticosteroids to get this disease initially in check. But then we have traditional systemic agents, which are tend to be immune suppressing. So they're certainly not my favorite, especially for this specific disease. And then the biologic systemic agents is really where I tend to lean, based upon their general low risk profile, even long term, and their ability to greatly improve a patient's quality of life. Topical therapies are like calcipotriene and topical tacrolimus. We've got our vitamin D analogs in calcipotriene, and our topical tacrolimus, which is our topical calcineurin inhibitor. I will point out that neither of these therapies is approved. Really, there is only one therapy approved to treat generalized pustular psoriasis, and that is spazolimab. Currently, there are several more in testing. Wet wraps, I think that this is something that in the world of nursing, we do so well, because we recognize that a wet wrap is a therapy that, in fact, may help a topical therapy such as topical corticosteroids, a TCI, or a vitamin D analog to actually penetrate the skin and be more effective. So I'm very apt to use a wet wrap, especially in a specific area where my patient was specifically concerned or having a lot of discomfort. Photochemotherapy with Sorlin or Puva, and ultraviolet light. Absolutely, especially if I had access. I think the sort of drawbacks here are that typically with phototherapy, I've got to have a patient that has access to a phototherapy booth or a phototherapy treatment center. And I've got to have a patient that is willing to show up 2 to 3 times a week. They're short visits, but they've got to be able to show up, feasible speaking, with their job, and with transportation. I think the key here, though, is really what's in bold, and that is these therapies should never be used alone as monotherapy for a patient with generalized pustular psoriasis, especially for those with more severe disease. Again, if I have a very specific problem, I want to use a very specific treatment so that I have the best outcome. And in this case, we want to use the approved therapy. So systemic corticosteroids, again, as I mentioned, they're very rapid in onset. I would never, and I repeat, never order a Medrol dose pack. That is absolutely inappropriate. I'm talking about a flare. So I'm talking about using kind of a step down and starting my patient depending on the extent of their disease, their comorbidities, and other history. I'm going to start my patient on a higher dose and I'm going to slowly taper this. We're going to use this short term during the acute flares, but never a dose pack. I'm going to caution its use in pregnant women um, because of the risk of cleft palate, especially in that early part of pregnancy. And I'm going to taper that dose slowly because rapid withdrawal may, in fact, induce a flare of this generalized pustular psoriasis. Traditional systemic therapies like acitretin, cyclosporin, and methotrexate, they're used, but again, they're not FDA approved to treat this. And there are issues in and of, depending on the age and the overall course and extent of this disease with your patient. Acitretin can unfortunately has a box warning. It should not be used in pregnancy. And unfortunately, there is a REMS system for acitretin use. Cyclosporin has this end organ damage for renal. And so we can't always use it. If we do, it's short term. And methotrexate, again, long term end organ damage for the liver hepatic system. A lot of monitoring has to go into each of these therapies listed on this page. And so, quite frankly, they're not really ultimately the best options involving the least amount of risk. So, as I mentioned, acitretin, we have this teratogenicity here with the ability to cause some birth defects. Specifically, you can cause articular issues with our bone, specifically our growth plates, specifically in younger patients. And so it's not always a great option. Cyclosporin is a calcineurin inhibitor. We should caution its use certainly in pregnant women. I would not be okay with using it in a pregnant woman. It can cause some hypertension. And again, as I mentioned, that long-term renal dysfunction. You have to monitor blood pressure, renal function, and it is an immune suppressing medication. Methotrexate is certainly not recommended for patients who are pregnant or nursing. Um, it can, in fact, cause end organ damage of the liver, and it's very, very slow in its onset. So, when it comes to these large molecule protein medications called biologic therapies, there is one current agent called spozolimab that is an interleukin 36 receptor inhibitor that is FDA approved to treat generalized pustular psoriasis. So in my clinic, I really, really like to use this therapy when possible, given that I have very specific data, and it's great data showing clearance of generalized pustular psoriasis in a pretty nice amount of patients, even after one dose. Uh, there are TNF alpha inhibitors. You see them listed here. Again, none of these other agents are currently approved, but they're certainly used at times. In addition, some interleukin 17 inhibitors that are used, as well as the interleukin 12/23 inhibitors that are used to treat in certain cases. So, spezolimab, as I mentioned, is the only FDA approved therapy for generalized pustular psoriasis flares in adult patients. This product was specifically developed for this diagnosis. Data indicates that we can prevent GPP flares up to 48 weeks. On a side note, in addition, that data shows that if your patient also has psoriasis, that too may be prevented. And they're currently watching it in a long term open label extension trial. This is a humanized selective antibody that blocks the activation of the interleukin 36 receptor, and therefore nothing happens downstream. And it is the only currently available as an infusion, which means you have to have access to an infusion center. There is a subcutaneous form of this in testing. So, what did we do before we had Spizzolimab? Well, this is a study that was published in JAMA in 2022. And this gives us some insight as to which therapies were leaned heavily on prior to the FDA approval as current. Of course, not surprised that a lot of patients got steroids systemically, as well as acitretin, cyclosporin, and methotrexate. And then additionally, we saw the other therapies listed here as well. In terms of investigational use to treat generalized pustular psoriasis, there is an interleukin 36 inhibitor called imsidolimab that is currently in testing, and then anakinra, which is an interleukin 1 inhibitor currently being tested to treat this condition. So, in summary, we recognize that generalized pustular psoriasis has this very profound short and long term impact on patients' lives. That topical therapies alone really are insufficient to control this disease. So, we've got to use a heavy hitter, preferably with low risk. If we use something topical, it really should only be in combination with one of our systemic biologic agents. And there are a variety of biologic agents that have demonstrated some efficacy in patients with generalized pustular psoriasis, but there's only one agent currently, that is Spizzolimab, that is indicated for adults with generalized pustular psoriasis. We will now move into the second part of our activity, and we're going to be discussing a clinical case study focused on the management of pustular psoriasis. And I am thrilled to bring in my esteemed colleague, Stephanie Simmerman, to help out with a segment. Hello, Stephanie.
Hi, Leanne. Thanks for having me today.
So here we go. A 54-year-old Caucasian male presented to his primary care provider with a 2-day history of, quote, the worst itching of my entire life, end quote. He had an erythematous rash. He had some scale noted on his trunk, his buttocks, his arms, his legs, and his feet. He was afebrile. He did report some nausea, and he was not sleeping because he was so itchy. He also reported having a mild headache, some joint pain, and extreme sensitivity to his fingertips and his feet. And it was really making like buttoning buttons and driving his manual transmission car extremely difficult. His past medical history was significant for hypertension, obesity, smoking, and he had a chronic, mild, scalp only psoriasis that had only been managed with topical therapy. His current medications included some lisinopril that he took daily in low dose and some clobetasol solution that he rarely to never used, involving the chronic history of mild psoriasis on his scalp. On physical exam, you notice that his skin is fiery red and very, very tender. When you touch his skin, he winces. He has marked scale involving the flexural areas, his genitals, his palms, and his soles, and very finite 2 to 3 millimeter pustules appearing diffusely on his entire trunk, palms, and soles. You also notice these sausage-shaped digits that we call dactylitis on several of his fingers and toes. And when you palpate them, he winces in pain. He is missing some fingernails on several of his swollen fingers, and the absence of fingernails here is called anonychia. This is an image of what you might see from our friends at DermNet. And let's talk about this patient. And so as you hear this, Stephanie, how are you possibly going to evaluate and document his symptoms? Like, what are your priorities and kind of where's your head going?
Yeah, it's a great case. Thank you for sharing it. I think, you begin with some of that DLQI that, we've spoken about. And really, we talk about so many of those things that he is experiencing, the impact that it's having on him in general, and his quality of life. And I think overall, looking at it in terms of his severity, right? Is he mild, moderate, severe? Really looking at evaluating those systemic signs and symptoms and drivers because of how that's going to impact some of our management, and accounting for his body surface area.
So how do you evaluate itch in your clinic? What do you use, a tool? Do you use a scale?
Yeah, I use our just standard, our itch scale, but 0 to 10, and I always say 0 being none, 10 being the worst in your life. Where are you at? I found it just super easy. I don't get out a tool. I found the verbal to be enough of a good prompt for people. How about yourself?
I love to use the peak pruritus NRS measure.
Yeah.
One thing I think is really helpful in clinic, I actually captured peak pruritus NRS 7 days. So last 7 days, worst itch, 0 is no itch, 10 is worst itch imaginable. And then I also do peak pruritus NRS 24, which is the last 24 hours. And so what that sort of gives me an idea of is how's today in the overall function of things. And you can
That's
kind
right.
of get a little bit of a feel for, are we getting better or are we headed to flare?
Yeah, I know one of our colleagues once said at a conference, it's that the snapshot versus the movie, right? And
Oh,
I
love
think that's
that.
fantastic.
Yeah. And so when you hear the dactylitis history with this gentleman's sausage-shaped digits, can you tell me if you think that this joint pain is likely to be inflammatory or non-inflammatory, and why?
I do. I think it's going to be inflammatory. We know that this is a systemic condition. And you're seeing some of the skin manifestations, right, of what's actually going on also internally. It's that kind of nice thing that we have about dermatology that lets you, it's like a little, a sneak peek, if you will. And us having those really good assessment skills kind of lets us know what else could be at play here, kind of putting the whole patient together.
I love that. And I really honestly think that's so incredibly important, is just the timing of when this all
Mhm.
occurred.
Yeah.
And even some of his past medical history just are leading me in the nature of, okay, I see pustules. He's got this history of mild scalp psoriasis. I definitely want to ask more questions, but the fact that this happened so acutely
Mhm.
around the time of his marked flare of this current inflammatory episode, it's just highly suspicious to be a component. And I agree, likely to be inflammatory.
When you
Uh,
started the case, I kind of chuckled for a minute. I'm like, wait a minute, is this the 4 p.m. Friday afternoon patient that walks in the door?
oh, most certainly.
Absolutely.
Absolutely. Yeah, yeah. Or he's scheduled for a skin exam at 4:30. And oh, and by the way,
Yes. And by the way,
yeah,
I have the
I
full
got
rep.
this rash. Yeah. So what would be included in your differential diagnosis for this gentleman?
That's a good one, because it can be pretty extensive depending on how creative you want to get with this. I've seen anything from a disseminated candidiasis to pemphigus. I've seen people talk about generalized tinea can be thrown in there. The kind of figuring out, is this drug related, right? Or is this an acute issue with the AGEP? The pemphigus falacius was one that I was like, oh, I have to go back and read on that one a little bit. And those are just some of my top differentials. How about yours?
Yeah, I agree. I think the pustules in this case, especially pustules involving his trunk, but his palms and his soles. For me, where are the pustules located? The fact that they're kind of at the trail, as we mentioned in the previous slide. When I'm examining palms and soles, if I've got pustules kind of web spaces up here, maybe fingers, and they're acutely itchy, I might be thinking something totally different than if I've actually got palmar involvement. And specifically, this kind of area of the palm right here. if I've got pustules there, immediately I'm thinking of pustular psoriasis. But I think it's really, really easy to sort of look at all of the body's surface area surrounded along with his clinical symptoms.
Mhm.
Um, I'm not really thinking about dyshydrotic eczema or scabies here for this
Right.
gentleman because he's in pain. He's complaining of pain. Even though
Mhm.
the itching sort of precluded this, once the rash occurred, he's having pain and he's no longer itchy. And so something that is not itchy is not atopic. It's not eczematous. And
Excellent
so
point.
that said, I think I'm ruling those things out automatically by his
Mhm.
history. And I think it's really simple to do a KOH prep at the bedside to rule out some tinea, maybe, and even a wound culture. Pretty,
Mhm.
pretty simple. And you're going to get those wound culture results back in maybe 48 to 72 hours. And that's going to give you at least a faster sort of rule out than if you maybe did some other tests that might take a little bit longer.
And I think that you have an excellent point, when you talk about the diagnostic tools that we have, right at our hands. And I once worked with a collaborative that said, you'll never regret ordering tests. It's the one you don't order that you're going to regret. And so when in doubt, just having those other right resources there to help you confirm, because this is so rare, right? And so,
I agree.
yeah, just having those utilizing the tools at hand.
So, are there any additional tests that you would order for this patient? Like, how would you come to your diagnosis? What would you do if this was your patient right now today?
I'm going to do a biopsy today. I'm also going to run some serum labs because we are suspecting the generalized, pustular psoriasis. And I'm going to talk to them about whether or not we're going to order radiographs or we're going to consult with rheumatology.
So, tell me, because you said biopsy, where would you think to biopsy this gentleman? Like, if you were looking at him head to toe, what are you looking for in terms of I want that spot right there?
Hmm. I think, in all honesty, if we approach this, I'm probably going to do a lesional and potentially, unless I'm super confident, I might do a perilesional biopsy as well and send it for DIF, unless I was really, really confident in my initial assessment.
Yeah, never to it's always harder when you have to call them back after the fact.
Hmm.
Um, so curiously, are you gonna do a shave or a punch?
I would do a punch.
Me too. Yeah, and what size do you typically?
I usually start at a 4, but I go between 4 and 6.
Yep, yep. And
Usually
I
a
would
4.
say I love that. And I think, because this is a dermatitis, sort of seeing all the layers of skin, which is what, if you're doing a punch biopsy, you should absolutely go down to the sub-Q layer.
Yeah.
And so we get full layers of skin that really help the pathologist sort of split it lengthwise and establish, okay, where is this process and what is it doing? And so a much better clinical picture with a punch biopsy.
I have found over the years that because we're referred into quite a bit in our clinic for rash management, and I have found that the shaves are usually where we have the hiccups and having to go back and explain to people, we need to do this again, and this is for this reason, because clinically this isn't correlating with what your path report is, and we treat patients, not reports, is usually my classic line.
Love that. That's a great saying. Might have to steal that one.
Go for it.
So this gentleman's dermatology life quality index, the DLQI, was 14,
Yeah. Can you
indicating that
imagine?
his current flare is having a significant effect on his quality of life. Radiographs revealed fusiform soft tissue swelling and periostitis of the second and third digits of the right hand, second digit of the left hand, and fourth digit of the left foot. Notice that these are not symmetric. I think I have to sort of focus our
Mhm.
attention to that here. And then his lab tests were all within normal limits, with the exception of some noted hypocalcemia. So, how might these findings change your diagnostic and management perspective for this patient?
I guess for me, I'm looking at it and I'm thinking, okay, to your point earlier, this is not just a topical, right? A condition I'm going to treat exclusively with monotherapy with topicals. So I know that we're going to need to step up our game a little bit here. And I know that there's been some innovation, right, within this disease state. And then so I'm immediately starting to think of systemic biologic treatment. And then I'm thinking, okay, how long is it going to take to get this person started on this, access, and that whole process? So what else can I do kind of immediately to simmer this down, get this person some improved quality of life, make sure that we don't let this get too far ahead of us. So I'm going to be thinking of doing potentially probably some steroids and a taper with that. I would still use topicals though, because you mentioned, right, his DLQI and the pain. And so in some of those inflammatory areas, what can I help decrease some of the inflammation with a topical corticosteroid? How about
Yeah,
you?
it honestly, I agree with everything you said. I want to hammer something home here just because I think it is a passion of mine in treating patients. This is a scenario where we have a gentleman with a systemic rash affecting a large portion of his body,
Yeah.
associated pain, inability to perform his activities of daily living, a very high DLQI score, and swollen digits that I think are inflammatory. So, that said, topical monotherapy should never be considered in this case. We are absolutely doing harm if we are not aggressively acting to put the stopwatch on those joints and to get this inflammatory disease in check. I think the other thing that I want to say here is it sort of brings up the point of what if you have the opposite scenario here, where you have a patient who maybe has a small body surface area, maybe 1 or 2%, but it's his hands and he
Mm.
can't function. How would that sort of, you've got small BSA, but you've got really big impact on his life quality? What do you think about that?
I think because of such a high risk zone, right, and the impact that that has on someone's overall life, mental health, ability to, right, earn a living, just open a door. I think that some areas on the body, they definitely escalate kind of the more sophisticated advanced immunotherapy treatment consideration and discussion. And I think it's really about opening that, the discussion with your patients essentially is just diving into it and saying, this is something that's available and out there. You can try to do these things with topicals because people are going to be apprehensive, right? You hear immune therapy, they're a little scared. You're talking injections or infusions. And so I think it's just something that sometimes we have to ease into the discussion, but it's also helping them a little bit, maybe like understand more about their condition, and that they don't have to suffer.
Absolutely. I know one of my favorite things to say to a patient is don't let the injection piece scare you. Diabetics have to learn how to inject themselves with insulin, by the way, a large molecule protein. So can you. And
Yeah.
so I think when you put it in that sense, I by no means am downgrading my full discussion of risks and benefits. But remember, this is a discussion, and we're going to give you all the options and make sure that my patients are educated to make the decision with you.
It's pretty impactful, right? When you have those discussions, right? When you, to your point, when, you have it together, it's not paternalistic medicine. I'm not telling you what to do, but I'm going to let you be the informed consumer.
Love that.
Yeah.
So this gentleman received 900 milligrams via infusion, dose 1 of spazolimab, and was also placed on an oral steroid taper. He was given some topical clobetasol solution just for his fingertips for pain relief, and he was supplemented with oral calcium. A week later, his rash and symptoms were improved. He was actually pretty happy, but there was some erythema that persisted on his hands, feet, as well as the right side of his abdomen. And due to an incomplete response, the patient received a second spazolimab 900 milligram dose via infusion.
That must have felt good to see the improvement so
Yes, he
quickly
was
for it.
so thrilled.
Good.
Really, quite frankly, going from that first visit where he was absolutely in crisis
Yeah.
to I think I'm pretty good. And believe it or not, that that last visit, after his first dose, we had to convince him to get the second dose. And we felt like we should because he still had activity, but we are like, no, let's go ahead.
No.
So 2 weeks later, he presented to the practice with no activity. In fact, no inflammatory component of his rash at all. His joint pain and his swelling had completely resolved, and he was working on smoking cessation.
And I like that you bring that back in, right? That whole patient, right? Those lifestyle modifications, right? We didn't just say, here's a drug, have a nice day, right? You're just trying to
Absolutely.
empower them to do better for themselves. That's
Yes,
wonderful. Yeah.
absolutely. Yep. And we know that, with pustular psoriasis, smoking is a known sort of contributor. And so at the very first visit, I'm like, here's the deal. This is a hard conversation, but if I don't tell you, who will? And
Yep.
so let's talk about smoking and how this is contributing to your current disease and your current flare.
Yeah.
And if we want to get this better, we need to stop smoking. So how can I help you? How could I partner?
Wonderful.
Thank you so much for
Oh, this
watching.
is so fun.
To receive ANCC credit hours for this activity, please complete the short post-test and evaluation, and keep an eye out for further DNA educational activities in the near future. Thank you, Stephanie, for joining.
Great job, Leanne. Thank you for having me.